As you heard, there are side effects from this type of approach. They resemble autoimmune disease, but they're not really like autoimmune disease because they don't last a lifetime. They represent a very temporary period when the immune system creates inflammation in different organs in the body. And the most important thing that can happen is that there be good communication between patients, nurses, and doctors and family members. That the sooner we find out about these side effects, the sooner we can intervene with simple outpatient interventions, such as using prednisone or medicines like that, and we can reverse these. Usually about 3 or 4 weeks of outpatient treatment can reverse most of the side effects. But the part in red is really the most important part. In thinking about what we can combine with ipilimumab in the future, we have had some examples. This is actually the clinical history of a patient of mine who had metastatic melanoma, had chemotherapy, had part of her lung removed, and then had an unresectable recurrence. And these are her CAT scans. And this unresectable recurrence is indicated by the arrow here. And she began ipilimumab in August of 2009. This is showing you her spleen, which is clear at the time, some lymph glands in the chest, and just a funny blood vessel in the liver over there. Over about a year and a half, things got a little bit worse. There are some dots now appearing in the spleen. These lymph glands are maybe a little bit bigger, and this largest tumor is a little bit larger and was beginning to cause pain. And so because it was causing pain, because this is where the roots of the spinal cord nerves come out, we asked one of our radiation doctors to radiate just that one tumor. And this is showing you a map of where the radiation was given. And that radiation was given in December, January 2011. Right after the radiation, if anything, these scans look a little bit worse. This is bigger, there's more there's more disease in the spleen. But then in April, all of a sudden, this gets a lot smaller, these go away, and the spleen is clear. And this is something that has been talked about in the radiation literature called the abscopal effect. And abscopal, I learned from my colleague at Johns Hopkins, Dr. Drake, means shooting from a distance. And that's really what we're doing here. We're turning a single tumor into essentially a site of vaccination by killing it in a very, very specific way, in this case with radiation. And if the immune system is properly tuned in the background, then that vaccination response will lead to the regression of even the tumors that were not radiated. And that's why sometimes when someone is getting a little bit worse on immunotherapy, oncologists may sometimes say, let's radiate one tumor, because maybe we can see a phenomenon like this. And so there are now clinical trials going on combining immunotherapy of various kinds with radiation therapy. In addition, as you've heard several times today, the PD1 pathway is of great interest to us. And this is another one of these molecular breaks that keeps T cells from getting hyperactivated. And in fact, tumors have co-opted some of the biology of PD1 in an effort to protect themselves by throwing up onto their surface a molecule called the PD1 ligand, which actually can cause a T cell to die more easily when it's near the tumor cell. So how clever those tumor cells can sometimes be to devise a way to avoid immune surveillance by killing the very T cell that are coming to kill them. And so therefore it's a very reasonable hypothesis that by blocking PD1 or blocking its ligand PD-L1, we actually can enhance tumor immunity. And as many of you know, there are several PD1 and PD1 blocking antibodies available now, some commercially, some still in clinical trials. This was some of the first data for nivolumab, which is not approved in the US, but is approved in Japan to treat metastatic melanoma. And this was data actually that was first presented by actually Dr. Topalian's group and then updated by Dr. Mario Schnall at Yale. And this shows individual growth curves with the lines going down being patients who are having reduction in tumor size with melanoma treated with nivolumab. And what you can see here is that some of these patients have that kind of funny response, like that liver metastasis situation that I shared with you, where here's a patient who got worse and then got a lot better. Here are patients who are getting better, but new tumors are developing along the way, which go away, even on the way to achieving a complete remission. So we have to be wary of these unusual response patterns with the PD1 blockade, just as we were with ipilimumab. This is some of the data for pembrolizumab, which, as you know, was approved just about a month ago for metastatic melanoma. And the important thing here, each one of these lines represents a patient's tumor burden increase or decrease. So if the lines are going up, then the drug is not working. If they're going down, then it is. And the yellow boxes are indicating patients who had previously received ipilimumab. And that's really important because, as you can see, there are just as many lines going down that are yellow that there are blue, which means that it doesn't matter if someone did not respond to ipilimumab. They can still equally well respond to PD1 blockade in this case. So that, for us, is a very good validation of science, but it's a very important source of hope as well. And this is just I think, pivotal data for our field. This was from Julie Bramer from the group at Johns Hopkins, showing that patients with advanced lung cancer can also benefit from PD1 pathway blockade. So because we've got both CTLA-4 and PD1, which are showing nice responses in patients with melanoma, we began a clinical trial around 4 years ago looking at the combination of the two approaches in patients with melanoma. And this is some of the data from this clinical trial that first started at Memorial and at Yale, but then opened by Dr. Atkins at Georgetown and Dr. Kirkwood at Pittsburgh, and then subsequently was open in phase 2 and phase 3 around the world. But this is using a combination, the standard dose of ipilimumab and 1 milligram per kilogram of nivolumab. And you can see here that these are very steep drops in the tumor burden in patients treated with the combination. In fact, 53% of the patients treated with this combination at these doses had these really steep drops. And these CAT scans got better very quickly. Each of these orange arrows is pointing to a different tumor that regressed by the first time that we looked. When we look at the overall survival for the patients who were in this admittedly small phase 1 study, we are seeing numbers that make us quite enthusiastic. In the cohort that I just told you about, 3 milligrams of ipilimumab, 1 milligram of nivolumab, the 2-year overall survival rate is 88%, which is a number that I have to say, as someone who's been treating this disease for 17 years, I really never thought I would see numbers like that. And even if it is a small subset, and even if this is a phase 1 trial, I think it's so radically different from what we would expect that it makes us grin. It really does. Excuse me? There were 53. So this is the total 53 patients treated with the combination, the 2-year overall survival of 79%. And I'll tell you that there will be data available, hopefully, in the next months to year or two from the phase 2 and phase 3 trial, which involved over 1,000 patients. So we hope to have more definitive data, which is comparing the combination with the component parts. There are also trials going on now that are looking at sequence therapy, whether giving one medicine and switching to the other or vice versa is better. So a lot of attention being paid to concurrent treatment and sequence treatment. I'm going to just finish now and say that we now have been looking at multiple different interactions between the immune system and tumor cells. This is something called the cancer immunity cycle, and it was put together by Dan Chen and Ira Melman in the journal Immunity last year. And this just shows you all the different steps in which tumor cells and immune cells can interact with each other, and things in green that make the process go better, things in red that make the process go worse. And now there are actually medicines in development, some already available, that either stop the bad things or help the good things. And so this is, I think, a very important example of how some success that has been shown already with CTLA-4 and PD1 pathway blockade has led to deep interest, both on the part of the scientific community, our colleagues in the industry, to help develop new medicines to attack this problem in many different points. So I'm going to finish there. This is my research team here, as well as our funders. These are the folks who largely do the work in the laboratory. And then, as many of you know, this is very important to bring this work to the clinic. And so we have an early phase 1 immunotherapy research team that makes sure that patients get access to these new medicines in the safest and most efficient manner possible. There are individuals in the room who can attest to that, and I have to give them my deepest sense of gratitude for the hard work that they do to make sure that we not only give access to these medicines, but that we do it in a safe and effective way. And finally, to remind everyone that immunotherapy is not something that's so totally new, but it's always been something that has been considered a source of significant imagination. And so even when folks were thinking about tackling the most difficult infectious diseases like polio, immunotherapy was out there as one possible source of great hope that emanated from their imagination. And this is actually etched into the stairway at the Salk Institute in La Jolla, California. I thought it's an appropriate place to stop. Thanks.